Meantime, the slides are put, we can start the panel. So I think recently just we had a nice discussion on the available options in small cell extensive disease. So I think it is very important and it is very pertinent that we select the best possible treatment for our patients, and also it requires a lot of efforts from the financial perspective. An important part is that we all understand, yes, small cell carcinoma is a difficult disease to treat. Sangeeta ma'am, I will request your comments. We know that platinum-based treatment response is very good, but how long is the treatment response sustained? What?
Yeah, Akhil. So, good morning. Thank you. I mean, usually it's the, we see the rest, if patients who are, obviously they're very chemosensitive, so, but then it's a short lasting response. You have the PFS mostly between the 6 to 8 months that, patients do come back for the sensitive patients. But we also look for, primary resistance where they have, that percentage of the patients are also there, where, they come back within 3 months of therapy.
That is very important point. So I think that is very important. The responses to platinum is always there, but the responses are not sustained. That is the main problem which we deal with the small cell cancers actually. So how to deal with that, how to utilize that, that is what we see. And in India, the incidence of small cell cancer is now significant due to increasing incidence of smoking. We know that smoking is bad, but I think at least 10% students post-DM, post-MCH are also smoking, knowing everything. So that's a problem in our country, and it is actually increasing in West significantly, though in India, I think the smoking problem is somewhat better controlled as compared to the West. Again, the problem related to brain metastasis. Deep, would you like to give comment on the brain mets part in small cell?
Small cell, we know that they have more propensity to go to brain. So even symptomatic or asymptomatic, almost half of the patients will be having baseline brain metastasis. And even if not, I mean, they have higher chances of metastasis even at progression also. So that is one problem that we have to deal with while we are treating small cell lung cancer.
Yes. Taravas, need your comments on the incidence. We initially used to think it is much rare in our country. And what is the situation in Jaipur and Rajasthan, where I think females are also smokers in a large numbers, especially the village areas? Your comment on that?
I think that incidence which you are quoting around 15% is okay, that this much in comparison to the lung cancer, this account around 15 to 20% of lung cancers are small cell lung cancer.
Okay.
Because so the smoking is most prevalent, especially in village areas.
Correct. So that is an important problem, and this is a very important problem, that his relative survival is actually very less for this disease, and the outcomes are really poor. And the main problem is that 2/3 of the patients in the Western data have present with extensive stage, and in our setups I think it is 90-95% present at extensive stage. In West it is to the tune of 67% with extensive disease, and in our country and in our scenario we find 90-95% patient at extensive stage. We hardly find a patient who is fit for CTRT and calling it as a limited stage disease. So let's see a case, a 50-year patient with no history of smoking, evaluated for cough and chest pain. How to evaluate? Would you do NGS in a patient with a small cell diagnosis? This is the scenario. Sangeeta ma'am?
So I'm routinely definitely not performing an NGS in small cell. I think, at least the first 2 lines, I definitely have nothing to offer them. I don't think there are really targetable mutations or biomarkers.
Completely agree. And if it is a transformation from non-small to small cell, then do you do NGS?
No.
Not much. Deep,
much.
what do you suggest?
Yeah, in that scenario, we may do. So if we have to see what baseline mutation status was.
So we see a lot of EGFR positive patients in Varanasi. I can quote the incidence is close to 47%, and we have a 5% small cell transformation ratio in EGFR.
So sometimes that may change too. So even treatment maybe will be same for initially small cell. We will have to treat it as a small cell lung cancer. But later on, if there are some mutations which are developing and you may add in treatment, maybe it may help to some extent.
Okay.
So in that scenario, maybe we can do it.
I just want to look, once it's transformed to small cell, are you seeing differences in the mutations?
Yes, there definitely we see some.
With small cell,
One is we always find in transformed retino RB1 gene mutation. That is a hallmark of transformed small cell actually. And other than that, we tend to get some more amount of MET and ALK and EGFR in such patients. Post EGFR, definitely it's difficult, but we tend to get some other rarer mutations more frequently in such patients. Especially, we have got NTRK as well in a transformed SCLC, which was initially non-small cell. So that is an important point. So I tend to do NGS on repeat biopsy because we already have tissue diagnosis post as transformation. Then only we have diagnosed that it is a transformed small cell. So that is a point. Another point is that if you get ALK IHC positive in a small cell, Deep, your comment, ALK IHC was done. Any comment on ALK IHC in a small cell?
So need to do other orthogonal or other testing for ALK also should not be there. So we should confirm it with some other tests also.
That's
like
very
fish
important point. In a small cell, if you perform an ALK IHC, there is a chances of 50% false positivity. So if in small cell or neuroendocrine cancers you are getting ALK positive, don't get confused. It might be there as a false positive and you have to confirm either by FISH or NGS. So that is an important point. In around 3% of small cell lung cancers, ALK might be positive, which is somewhat similar to non-small cell. In actually non-small cell, our incidence is 5.7% in our institute and also TMH Mumbai. But yes, that is a point. For ALK, you need to be sure, and IHC is not confirmatory in case of small cell. This is a very important point, which I learned the hard way. IHC was reported by our pathologist as positive. We started ALK-directed treatment, and patient progressed rapidly. And when we did a NGS, their fusion was not being detected. And then I could read that it is reported false positivity of ALK IHC is very important, and it has been reported in small cell. So that was a learning point to me a few 2 years back, and that I think all of us should know. So coming back to this case, if you see this is a large volume disease, small cell, and there is at least there's no brain metastasis, we always do brain imaging, we have discussed already. Cis versus carbo, important point. Sangeeta ma'am, your comments?
With an extensive, I'm fine. If the patient is fit for cisplatin, I do go for cisplatin. If not, it's okay.
That's a very fair point. Preferable is to utilize cisplatin because of its rapid responses and rapid results. Carboplatin versus cisplatin, overall results seem to be same, but yes, the response rates are much faster with cisplatin, that we know, and that is why we try to utilize cisplatin wherever feasible. But the only problem is that if the patient is having SVCO, another problem, it is difficult to give proper hydration, and we want to restrict fluids. Most of the time we tend to utilize pre-phase carboplatin and so such. Tarachan boss, do you agree?
Yeah.
Completely agree. Okay. So one more point, the number of cycles of platinum based treatment. Dr. Deep, would you like to comment? 4, 6 or somewhat higher or somewhat lower?
Yeah, 4 or 6. So try to go for 6, but not compulsorily. If tolerating well fit patients, maybe go for 6, but usually we try to go for 6.
Okay. And when you are planning treatment with cisplatin, what is the dose we utilize? It is 25 mg per meter square day 1, day 2, 33 mg per meter square day 1, day 2, day 3, or 50 mg per meter square day 1, day 2. What is your schedule?
Yeah, it comes around 75. So 33 day 1, day 2, usually 37.5 something day 1, day 2.
So you tend to utilize 75 mg per meter square like in most of the situations. So there is an option to utilize 100 mg per meter square also. And in both NEC and a small cell, it is preferable to utilize either 100 mg per meter square divided in 3 days, or whatever 50 mg per meter square day 1, day 2. That is the preferred point. That is another learning point which is somewhat different from other cancers, where we tend to give more of 75 mg per meter square. Here the dose is 100 mg per meter square, preferred dose. Again, if starting a patient is PS3, Tarachan boss, patient presented to you with PS3, how would you start the treatment? Patient is PS3, creat is 1.5, how should we go ahead?
Go with the single agent carboplatin, because the small cell lung cancers respond beautifully to the chemotherapy, even single agent. Even in PS3-4 patient is on continuous oxygen flow and etc. But patient respond, and I think within 1 or 2 week patient become fit for the full dose treatment.
Yes.
It happens usually.
Definitely, I completely agree. That is the way we all treat the patients, and most time PDL1 is not being done. Everyone of us will agree. Yes, yes. So this is the trial setting, the ES SCLC trial, the durvalumab trial, which we are all aware of. There is an option to utilize immunotherapy. There are two options now. We are aware, Atezo and Durva. Atezo got approval in 2018, Durva in 2019. So we know that this is an unmet need. And what is the advantage with the regimen with Durva? That it becomes 4 weekly maintenance later on, but Atezo, it is usually given 3 weekly maintenance later on as well. This is the slide which shows the key criteria of inclusion, exclusion, and primary endpoint of overall survival. So again, an important point is that in all small cell lung cancer trials, you will see the primary endpoint of overall survival. Even in urinary bladder cancer maintenance avelumab, you will see primary endpoint of overall survival. So it is preferable to have a primary endpoint of overall survival when you are dealing with immunotherapy, even in advanced and extensive stage of disease. So these are the salient points. Durvalumab 1500 milligram was given 3 weekly along with platinum etoposide for 4 cycles, followed by 4 weekly maintenance. Both cisplatin and carboplatin was allowed, so that is giving us some leverage and advantage that you can utilize either cis or carbo. OS is the final endpoint and can receive up to 6 cycles. In the Atezo trial, it was 4 cycles. So as we all agree, if patient is tolerating well, we try to continue up to 6 cycles. PCI was offered in the control arm only and not during Durva maintenance, and asymptomatic as well as treated and stable brain metastases were included. So that is another plus point of this trial which we are discussing just now, Caspian. This is the data which we are aware. PFS is somewhat improved. If you see the OS, the curves start to separate after 6 to 8 months, and you can see it is getting significant separation, and at 3 years also you can see significant separation in the curve. That is what is important, and that is the key to it. So long-term durable responses are the key with immunotherapy, which we can see here, 4% versus 14% survival at 2 years and beyond. So this is what we do actually, and I think safety, we are all aware, there's nothing much difference from other immunotherapies. So how to choose, what to choose, how to compare, that is a point which we are coming. Coming back to the case which we are discussing, this is the case where there was extensive disease. The patient responded good to chemotherapy plus IO combination. That is what we see very commonly. The main problem is sustaining the response. And here the patient is continued on Durva maintenance, and after close to a year, the patient developed progressive lesions, and patient received PAL-RT and for next cycle of treatment. So first discussing the choice of the treatment, I will take comments from all of you. Sangeeta ma'am, first you, how do you choose between the two? Is there any specific way, or it is both you are do? Yeah.
You mean to say the choice of immunotherapy?
Choice of
or
immunotherapy.
Is it the
Choice of immunotherapy.
I think I would choose of either one. Only with the one thing is the obviously when the patient is fit for immunotherapy, the choice of durvalumab being 4 weekly maintenance is a little better. And other than that, I think about the load of liver lesions also. Really to choose the immunotherapy in them.
And also, if you are utilizing cisplatin.
Yes.
Because this trial only included cisplatin, while
yes,
Atezo trial included only carboplatin.
carboplatin.
So that gives us.
That is also good.
Same comments or any difference? I think all of us will agree with that. Yes. So this patient then finally progressed. Now what are the options? Dr. Deep, what do you think are the available options in the second line treatment for this patient?
Progressed when?
Post 6 months of platinum. This patient has 6 months of PFS at least.
Yeah.
So what would
on,
you re-challenge?
On maintenance, patient has progressed.
Yes,
on
upon maintenance with Durva. Yes.
So we'll give chemo again, platinum-based doublet chemotherapy again.
So you'll utilize carbo topo again, correct?
Yeah.
Yeah. So that is fine, and it depends on the platinum-free interval which you try to highlight.
Yeah.
So that is a fair point. If patient has progression within 4 to 5 months, it is doubtful to give benefit, but in at least small cell, sometimes it is considered, even 3 months is considered a cutoff for re-challenge of platinum, I think. Yes. it is somewhat different than other cancers, where in ovarian cancer where you take a cut of 6 months, in a small cell we try to take a cut of 3 months. This is because there are no very good agents down the line. So that is an important part and difference, where in ovary we have at least some options available down the line. Here there are very limited options. Thankfully lurbinectedin will be available to us, and as we were discussing yesterday as well, to us very shortly. So this patient then received, you can see the patient had responses, but this patient's progressed. So now coming to some comment on the PCI. Tarasan boss, you have reviewed the data and you are presenting the extensive stage. So what do you think about the PCI?
I think if patient is responded well and not symptomatic or not having brain mets or not symptomatic, then PCI can be avoided if we are ready to monitor 3 monthly MRI brain.
MRI brain. So I think yes, and the Japanese trial is available, which shows MRI surveillance is a good option and non-inferior option. It is an option, but if the patient is non-compliant, it's difficult. So according to the situation and individual patient, we need to individualize.
I thought PCI increases the survival, is it? So if the patient has got good response and giving a PCI, does it really matter for the survival? I thought somewhere read that it does increase the survival. So
but the problem is that all the trials of the PCI were done in era where immunotherapy maintenance was not being utilized. So in these trials, PCI was allowed in the control arm in this trial. In Atezo trial, it was allowed even in the experimental arm. But the problem is that PCI has never shown a survival benefit along with immunomaintenance till now. So the previous trials were in non-IO era actually. So this is what we discuss and we understand. These are the 2 important points which need to highlight it. You can see untreated brain metastases were included in this study, Caspian, which is a very important point, because around 30% of the patients have some amount of brain metastasis. It might be symptomatic or asymptomatic. PCI was allowed in the control arm. PCI allowed in experimental arm in IMpower 133. Up to 6 cycles of chemotherapy were allowed in the control arm in Caspian, making it more powerful control arm. So that is an important point. That is a very important point which separates IMpower 133 from Caspian, because if we are not giving immunotherapy, we tend to utilize at least 6 cycles of chemotherapy, while in IMpower they allowed only 4 cycles of chemotherapy even in the control arm. Cisplatin was also allowed. So these are some important differentiating points between the 2 trials that helps us in selection. And as we have already covered and discussed, we need to include as per the situation of the patients and inclusion criteria of these trials. Good point is that Caspian allowed treatment with the real world scenario which we face, including brain metastasis with either CIS or ITPO, and also 6 cycles of chemotherapy in the comparable. So thus we can summarize that it is a very important option to utilize immunotherapy, and thankfully costs have also come down. There is some enhanced assistance program with durvalumab also now available, which makes it somewhat easier to utilize. Still, we cannot utilize it for more than 80% of our patients, but at least some patients can be put on this treatment, and survival has actually tripled at 3 years duration. So I think we can stop here in the interest of time. Thank you to the panelists for the discussion. Thank you.
What about the case which we just discussed, that 6 months he progressed, and what about immunotherapy in that case? We can give repeat. So it depends on.
So if it is progressed on IO, I don't think it is a very meaningful.
But if it is mild progression here and there, you reintroduce chemo and continue.
You can consider even ablating that lesion or giving radiation to a single progressing lesion.
So basically, case to case basis, you have to decide.
I think RCC T-Nivo2 is out, and re-challenge with immunotherapy is not good.
Re-challenge immunotherapy has not worked anywhere till now. So I think
if the patient is on maintenance, I mean continuing it along with another standard of, that's what you did.
Yeah.
So we have continued the immunotherapy.
So whether that will help,
that
we don't.
Is also been, I think, studied in small cell, the continuation of immunotherapy.
That is considered an option, but I will consider if the patient had good maintenance phase, for example, a year.
Good response.
Yes. Thank you.